I want to introduce myself a little bit. My name is Anelia Shaheed. I'm a licensed attorney practicing in Florida, but I have spent most of my professional career working with substance abuse and mental health providers. And during my law school years, I actually ran a large medical billing company that dealt specifically with mental health and substance abuse providers. And then as I continued practicing, I've started working now directly with legal issues that have affected payers, providers, patients, a lot of different areas. So hopefully today, my goal is to outline some of the things that I feel providers should be aware of in their operations. You know, you go to school, you learn about treatment, you're passionate about what you do, you care about clinicians, you care about doing the right thing, but nobody ever tells you what the Fair Labor Trade Standards Acts are, or what Erisa is, or that you need to make sure your HIPAA is compliant with this, or your email is compliant with that. So what I'm going to try to do today is outline some of the key things that I want any provider to take away, touch on some of the basic laws that will apply, explain how you should go back and say, hey, attorney, I need you to help me explain what laws apply to my practice, because I'll tell you this, healthcare is considered one of the most intricate and complex areas of law to practice. And it's up there with income tax and tax laws and things like that. It's not very easy. You can't really Google and find a nice summary on what applies, or you can't really say, I know the difference between federal and state law, or does California law apply if my patient's coming from New York? So I want to give some basic guidance on those areas, and then go from there. Now, just let's get a little bit of the disclosures out of the way for this conference. I am not actually sponsored by anyone. I am very passionate about this business. I've seen all areas of it. I've seen how patients have been affected. I've seen how providers have been disenfranchised. And I've seen that there's not a lot of advocacy. There's not a lot of people who care. And this is a very passionate industry about treating people, but there's not a lot of third-party people helping you. So I'm here on my own accord, so I actually don't have any financial disclosures or anything like that today. And I do want to let anyone in the room know, even though I practice in Florida, I've developed a network with our firm of different areas, different attorneys who practice similar to what we do. And we're all great on sharing information. So if you're from a different state and you want to find out about Texas or New York, we have colleagues that I can refer you to those areas that I have worked with that I know will give you the same quality of information that I would give you on Florida. And I am going to talk a little bit on California because I'm assuming that we have a lot of California providers here. But I know this industry is nationwide, so it's going to affect different people. The other disclaimer that I have to give is that this is, of course, not intended to create an attorney-client relationship, and I'm not necessarily giving legal advice. Take this as an educational workshop to give you a starting point. Obviously, anything that you do, you should confer with your own local counsel and make sure that those questions are specifically addressed there. All right, so I want to start a little bit and talk about what's been in the news, because substance abuse has been in the news. Mental health has been in the news. We've seen a lot of different areas. Especially recently, we've seen a lot of fraud and task force and takedowns by the government, by individual payers. And I wanted to digest some of these numbers because I've been in this area now for about 10 years. And 10 years ago, it was nothing like it was today. You did not need to worry about huge overpayments and recoveries and recoupments, or have problems getting benefits verified, or have to fight to get 2 days of IOP certed. It never was like that. It was much easier, and I think everyone was much happier back then. But then you had the ACA get passed, and you had a lot of law change. And what I said with mental health and parity and with the Affordable Care Act, which is the ACA, and I may use that interchangeably, that put substance abuse and mental health under the radar. All of a sudden, the talk changed, it shifted. The paradigm was no longer that people didn't talk about addiction, families didn't talk about addictions, physicians and major medical practitioners didn't talk about that before. And all of a sudden, it became something that everyone had to talk about. And when that happened, it also became an area that people started focusing on with the numbers. Because now they have to say, okay, well, if I have to offer in parity the same substance abuse benefit that I do for major medical, I'm going to make sure that I'm managing my costs, because now they have an additional burden. Or if a provider has to treat, well, I'm going to make sure that provider is held to the same standard as a medical provider or a hospital setting. So you saw a lot of things happen and changes happen, and part of those changes were a lot of these task force. Now, on the screen here, I have some of the numbers that have occurred recently with task force, and I wanted to highlight especially the size of these numbers, that there's been over $700 million in false billing that's been taken back, that there's been indictments, that there have been different kind of actions taken by the government agencies, and then also highlight how far this is expanding. Like, they're expected to reach 3.2 trillion in 2015 in healthcare expenditures. So people who pay for this and people who are going into treatment need to be aware of it, because now we're part of it. We're no longer an isolated industry. We're no longer by ourselves. We may still be treated that way, but we're gradually getting pushed into compliance with what everyone else in healthcare should be doing. The other really key thing I want to highlight is this last statistic here, which says that for there's an average return of $7.70 for every dollar return invested in fraud or investigations. What that means is that anytime a task force, and this is actually a government statistic, this was the Medicare number, but every time the government invests $1, they are receiving in return $7.70, which is a huge, huge number. So if you think about my average investment and your return, if you're getting $7 every time you conducted an overpayment request or an audit, that's a huge return for these providers and for these payers. So they are investing the money in these types of litigation. They're going forward and saying, we're going to go ahead and investigate for compliance. We're going to send recoupments. We're going to send overpayment requests. So you, as the provider, need to be aware of the potential that they have, the upside that's tremendously huge. The other thing that we've seen recently are a lot of news going on about fraud, about schemes and plans and things like that, where people are getting taken advantage of in substance abuse. In Florida, there was a large issue with marketers or independent providers trying to purchase or help patients purchase insurance on the Affordable Care Exchange Act. So what that means is that I, as a patient, I have no insurance. I call a call center or I call a provider. And provider not knowing, say, hey, you know what? You may qualify for insurance off the Affordable Care Exchange. Let's go ahead and get you insurance. You know what? I'll pay for your first month premium, or I'll pay for your premium so you can come in and get help, or you can go to a treatment center and get help and utilize that insurance. And what's happened is that there's laws that say that's prohibitive. And there are people who are not realizing that you have to be a licensed insurance agent in many states to be able to sell or offer information on insurance. They're not aware of that. They're violating that law by helping the patient buy an insurance policy. Paying for a premium can be considered enticement. It's also actually explicitly prohibited under the ACA. A third party is not allowed to pay for a premium under the Affordable Care Act. So you as a provider thinking you're doing the right thing and helping the patient and helping them get into treatment, all of a sudden has technically violated two major laws. And what's happened, it got to the extent where the insurance companies got the wind of this and they said, this is a big issue. We have a lot of people buying insurance and utilizing the benefit, and you know what? They can't do it the way they were doing it. So I just want to highlight that. That was another huge issue that came up in the industry that affected a lot of people. California providers will know this too. You know, HealthNet, this happened, I believe HealthNet was one of the main or one of the beneficial premiums that were offered on the CalNet exchange. So that same practice that was happening with Cigna in Florida was happening here in California with HealthNet, and that was another issue that came up. And then, I like to also highlight the other side to this, that while they're attacking providers and they're taking away benefits and they're making it really hard for patients to get care, they're making record profits. I mean, I would love to be the CEO of Cigna and make $49 million. I think all of us would. But I like to highlight both sides. So they're not always, they may have some valid reasons, but they're not always the good guy either. And then, just to kind of close on what's going on in the industry are the headlines and what's going on with the families and the patients and the people who need help. 21 million Americans right now have some type of addiction. That's a horrible statistic. There's twice as many addiction-related deaths than there is homicide in the nation. That's a horrible statistic. And I know that this industry is very small, and I know that everyone here is full and they're busy and they're trying to help, and you're dealing with an incredibly difficult type of patient. And to have these kinds of statistics just means that all the other issues in the news need to always go back and focus on these statistics. That ideally, we need to get these numbers down. Ideally, we need to help people. We need to have programs. We need to have legislation. And we all need to be educated so that we cannot have to worry about dealing with all the other issues that come up and focus on getting these numbers to go down. So to kind of do that, I want to focus on how do I run a treatment center and help those that need it, and still I'm compliant with the law, can grow my business and prepare for issues. So I'm going to kind of outline my presentation in those three areas. So the law, what do I need to know? How many of you in here went to law school? 2, okay, yay. So I'm sure none of you actually said, I'm going to open a treatment center and no, I'm also going to go and invest all my time to go to law school and figure out what laws apply to healthcare. Like I said, to start with, the law is a complicated issue. People go to law school for years and it's still confusing when you get out of it. So I want to give you a primer on, hey, this is how you understand what applies to you, and these are some key statutes and what they mean. And I want you to take that information and go back to your practice and say, I'm going to get someone to give me an outline of these laws and how they apply to my practice. Okay, so to start off with, we always have 2 areas of the law that you have to be concerned with, both the federal and the state law. And they apply differently, and I'm going to break them down individually. I'm going to start with the federal laws. Okay, so federal law is basically law promulgated by Congress, it's passed by the president, and what they will do is they will say, okay, we're going to pass a law that applies nationwide. Now, even though the law applies nationwide, there usually are provisions that apply to certain areas, there's certain exclusions, there's certain things. So I always recommend looking at what your federal law is. And when you're looking at what the federal law is, you have to make sure it's applicable to the situation that you're doing. Like a very common example is, I get questions a lot of time about kickbacks and Erisa and things like that. And I'm actually going to go into those 2 laws in much more detail. But a lot of times they may not apply to you. Straightforward example, if you're not taking any type of federal payers, you're not taking Medicare or Medicaid, you don't have to worry about Stark. Or if you're not a physician, you don't have to worry about Stark necessarily at the federal level. But then you break that down now and you have to go look at your state. And we'll get into that. Some of the laws are also broad and they regulate large areas. So for example, how many of you have ever heard of like the mail law, federal mail law? Nobody? You know that it can actually apply to you. You would not think that the mail, like the mail fraud law would apply to you at the federal level. But if you're sending mail or sending claims or sending any type of correspondence via the federal mail, and any of that mail has to do with fraud, like in the perpetration of fraud or any type of scheme to devise the government, you can actually be violating that law. And we're going to go to that law too. And then the other thing I want to highlight here is that even though a federal law may not apply to you, the state that you reside in or the state in which the plan originates from may have a state law that applies to you. So just take that. Even though the federal law has something at the high level and you say, oh, well, you know what, I don't have to worry about Stark or I don't have to worry about kickback. But you look at your state law, there may be a very restrictive state law that applies to you. So up here I have a list of what I would consider the basic federal laws that you should be familiar with, because I've seen some type of application in healthcare to these laws. We have the False Claims Act, the Medicare and Medicaid fraud statute, healthcare fraud statutes. We have the Stark and physician self-referral laws. We have false statement statutes, the mail and wire fraud statutes that I was mentioning earlier, the document alterations and destruction statute, theft of honest services, the exclusion statute, the anti-kickback statutes, and the Physician Payment Sunshine Act. I'm going to kind of go into a few of these in very particular fashion in a little bit, but I also want to highlight that a lot of these laws impose burdens on you as the provider. So you as the provider have to know that if this law applies to me, it's a burden on me. It has a negative implication if I violate this law. Now, at the same token, there are federal laws that benefit you. There are some federal laws that you may not be taking advantage of. There's the Employee Retirement Income Security Act of 1974, commonly known as Erisa. The Affordable Care Act, as I mentioned, also known as the ACA or the Obamacare Act, mental health and parity, and then HIPAA. And these laws actually give you rights. And you may not be aware of your rights as a provider, and they actually give patients rights, and the patient may not be aware of it. So when you're doing that whole kind of digestion and policy and procedure creation, you also want to say, what are the laws that I can use to help my practice when something goes wrong? And we'll go into it in a little bit detail, but I want to highlight there's both good and bad. At the same token, like I said, state laws that you should be aware of that may have negative implications are most states have false claims acts. They have health insurance fraud statutes, insurance fraud statutes, anti-patient brokering statutes, anti-self-referral or self-referral laws, and also state reporting requirements. If you're licensed, you may have to report certain violations or certain patient history issues to a third party, things like that. Certain states also make you report the number of patients you have, things like that. And like I said, each state law varies, so you have to look at your particular state in which you operate in. State laws actually also have a lot more beneficial laws than the federal government does for providers. A lot of states, about 24 states in the United States, have laws that talk about assignments. An assignment of benefit or assignment right is when you assign your right of payment or assign a right of receiving a benefit to a third party or someone else. Those can benefit you tremendously. I've seen a lot of times what will happen with an insurer is they will say, well, we don't recognize an assignment. You can't say that. You can't choose as a private commercial insurer just to say, I'm not going to recognize an assignment of benefit. What regulates it is the state law in which the plan originates from. So, for example, Florida is one of the states that has an assignment of benefit law. And the statute specifically states that if a patient who is a substance abuse or mental health patient executes an assignment of benefit and that plan originates in Florida, so the patient lives in Florida, the plan originates in Florida, that assignment of benefit law must apply. So if the government wants to say, or a payer say, UMR is a great example. UMR wants to say, well, we don't recognize an assignment of benefit. In my personal opinion, I think UMR recognizes nothing, but that's just my opinion. But we're not going to recognize your assignment of benefit. Well, you don't have the right to say that because what's the governing rule here is what the state law is. So again, I want to highlight that. This is one of those state laws that can benefit you. It's really important to know that, have a list prepared for you. If you got a patient coming in, you're having a payment issue, or you're having an issue getting benefits, or you're having an issue with the family, really good law to know. The other one I want to highlight are balance billing provisions. Balance billing refers to when you're billing a certain fee for service, and say the insurance company only allows a certain percentage. They allow 50% of what you bill. So you have a remaining 50% that's outstanding. That amount is what's considered the balance bill. And you can actually go after and collect in certain circumstances, or you cannot. California, for example, is one state that actually has laws that says you can't balance bill. Texas is another state that says you can't balance bill in certain circumstances. So it's important to know that you're not violating the law by balance billing a patient, or that you are actually in the opposite, that you're complying with the law by not balance billing the patient. This is a perfect example with HealthNet. HealthNet had an issue with the sending out statements, patient responsibility, and balance billing. HealthNet did not take the time to confer with their counsel to say, hey, is there any laws that would actually make it illegal for a provider to balance bill? Come to find out, in certain states, like Texas, the provider cannot balance bill. So telling them that they're violating the member's plan by not balance billing is wrong. The provider was doing the right thing. HealthNet was incorrect. But by just knowing that and taking the time to research your state law and taking to know what your requirements are, it was an easy argument to say, hey, HealthNet, you saying that I'm doing something wrong, you're wrong. In this state, I cannot balance bill. So I cannot give you statements showing that I am balance billing. And that was an easy thing to fix, and it took a phone call. But again, it's knowing the rule. The other thing that I like to highlight are unfair insurance trade practices. There's state statutes that actually say an insurance company cannot do certain things, or a managed care organization cannot do certain things. And if they are engaging in a scheme or a system of practice that they're, say, for example, refusing to quote benefits, or they're refusing to pay claims, or things like that, you can utilize those unfair insurance trade practices statutes. And some of the states do have private causes of actions in those statutes, meaning that you, as the person who's being injured, can sue under that statute, saying that the insurance company, hey, Cigna, you're doing something completely wrong. Or Aetna, you can't do that. This is a scheme to defraud. You see this a lot of times with cases that involve allowables. There was a large case, which was the Optum Ingenix case. That was a few years ago. What happened, Ingenix was the pricing agent for Optum, who was the payer. And Ingenix used their own internal database, and they said, we're coming up with our own pricing, and we're doing what we want to do. And the court said, no, that's an unfair insurance trade practice, because how do you engage in a practice that you don't disclose information to, that you don't tell people how it's supposed to pay, that it's your own determination of the allowable without utilizing national data or utilizing public resources? And this was a case that actually had a count that involved unfair insured trade practices in the state of New York. So I want to highlight that. Yeah?
Where the patient comes from to a different state, which rules?
The rule of thumb is, it actually is not where the patient comes from, it's where the plan originates from. So you always have to know where the plan comes from. So for example, if the patient lives in Pennsylvania, their employer is Morgan Stanley, the Morgan Stanley plan that's based in New York, that's where they're, I'm just using this as an example because I just have this matter right now, that New York is where the plan originates from, so New York law governs it. So, and actually, if for large employer groups, there's a website you can go to that will actually tell you where they have to register, they have to file a form, which I think is like the 550, I forgot what it is. But they actually have to file this form every time that a health plan is originated from, and it'll tell you the state, and it'll also tell you who the plan administrator is. Yes?
So are you saying that the pricing companies, if they tell you that they have their own system of creating their pricing, that's illegal?
It's not necessarily legal, but it's actually a good starting point for you. And I know it's like a little bit of work, but what you need to do is say, okay, well, where does this plan originate from? And if, for example, it originates in New York, Morgan Stanley is a perfect example of this. if that plan originates in New York, and I know New York has an unfair insurance trade practices, and this has been deemed a prohibited practice in New York, I can say that I know that your pricing structure is prohibited under this plan, and it's also prohibited under the unfair insurance trade practices. Do you want to go back and renegotiate this or pay an additional fee?
Okay. And then
So always go back to the plan.
they state that in these negotiations that you cannot balance qualification on this if you accept an offer.
Right.
Is that accurate or is that?
Yes, okay, so just to kind of talk about this. One, there's one legal principle in law, and you probably ran into this in other areas of your life when you've signed a contract for a car rental or you've gone anywhere. You can contract your rights away as long as it's not prohibited in law. So you can agree, as long as like there's no state requirement that mandates you balance bill. If the state or the federal law mandates it, then you can't contract that right away. But if there is no law that governs it, yes, you can contract your right away to do that. So it is permissible. So again, like going back to the key thing I started with is that this is a primer, and I want to give you guys some ideas of what I need to go back and find somebody who can advise me on these issues in detail as how it would apply to my practice. Because the question that you just raised is a perfect practical application question that affects a lot of people, because you think that, well, am I violating the law? Am I doing the right thing? Am I doing the wrong thing now? How do I create a policy for it? So it's a great question. It kind of also leads into the other points I want to highlight on here, which are, there's also general civil types of causes of action that you can bring. We brought a cause of action for defamation because we had an insurer who was saying that my provider was not a provider. So we were like, no, that's defamation because it's a statement that they're making that is injurious and untrue. So also look at those types of causes of action. You may have a simple breach of contract if you have a contract like that and they don't pay you. I've seen that happen where you sign a negotiation and they still pay you incorrectly. That's a breach of contract claim now because now you had a signed agreement and you breached that agreement. So you can just say, well, you're just in breach of contract. I can sue you in small claims court if I wanted to, or wherever you needed to. But there's also general civil causes of action that you can bring. Defamation we see a lot. And then the other things that you should know are the prompt pay statutes in your state and the any willing provider statute. How many of you have ever tried to go in network with an insurance company? How hard has it been? Like almost impossible because they don't want you to go in network, but they don't want to pay you out of network. It's important to know in your state if you have an any willing provider statute. Kentucky is a state that has one, for example, and I use this to try to help somebody get a contract with Anthem. They were not willing to contract. Well, we have an any willing provider statute in our state that says that if I want to contract with a managed care organization or an insurance company, that I must be given the opportunity to contract. And if I'm not given that opportunity, then I'm violating the state law. So that actually can help you in certain circumstances. I highly recommend you look for that statute. Okay, I want to go into a little bit of the detail, and I know I have the full statutes up here. I may get a little intricate. I'm going to try to break them down and make it really simple. Yeah?
This was really about the last slide.
Okay.
I wanted to wait till you moved on to.
I can go back.
Yeah, okay, thank you. There are, apart from this, as you know, in the complaint of both Cigna and United for Sky, against Sky policy, they highlighted co-pays and deductibles and classified that as fraudulent practice.
Right.
Amongst the other things as well, that they also try and control what they might authorize a certain level of care, whereas we as the providers might decide that I will not limit you to a suicidal patient. I don't want them to be at the HP level of care. So the peer review has decided that they are
right.
And if the patient commits suicide, we are the ones
responsible.
Responsible, not the insurance company. So they would say we are not providing the medical care. So between a rock and a hard place for them. So to what extent? So my question covers all those points that bother us. To what extent are the insurance companies then dictated how we provide care.
Well-
And how is it that when you provide a higher level of care at your own expense, this is either considered to be fraudulent,
Right.
or this is considered to be bad practice?
Okay, well actually your question, which I think kind of goes to what happens when I disagree with an insurance company and that they're always right and I always seem to be wrong, actually goes to, and this, in particular with what's happened in the industry, just to kind of go over that, we've seen that traditionally a lot of providers would provide a higher level of care of services and bill a lower level of care. And this actually relates to the False Claims Act. I know I have the federal one up here, but I'm going to use this example in question to kind of explain the insurance company's legal opinion on why they are correct about it being wrong for you to provide more care than what you bill. And I will, so basically what's happened is say a patient comes in at residential and they only say, well, he can have 5 days of residential. You disagree. You say the patient has a lot of clinical criteria, they meet their guidelines for medical necessity. I'm going to bill PHP and step in out of PHP, but continue to keep him at the residential level of care. Technically, and this is legally and technically, by doing that, you're making a misrepresentation of fact about the services you're providing. And that is the legal principle that the insurance companies are relying on to say that what you're doing is fraud. Now, you've historically seen this when in the opposite direction, when you bill residential, but you only provided IOP. So you're upcoding. That's the term of art that they use. And upcoding has been historically, considered definitely fraud, definitely an issue with false claims and misrepresenting services. Now, like I said, insurance companies have taken the position that legally, by even doing downcoding, you're violating the letter of the law by making a misrepresentation on a claim that you are submitting. So that is their legal position. And as a side note to that, the second point you bring up, well, how is it fair that I'm hurting the patient, I'm providing better services for the patient, and I'm not billing the insurance company or causing them excess loss? That's an issue, in all honesty, that has not been litigated. And it's being litigated right now in one case in Texas involving a hospital, and the outcome of that case is going to be very key. Before that, there was only one other case on point where the judge addressed the issue of downcoding, and the judge has said, well, hey, in his opinion, he said, well, if you decide to downcode and you are providing free services, that's not a legal issue, it's really just dumb. That was in his opinion. But so you can see it's an issue that there is no legal precedent to say the insurance companies have the letter of the law, but they don't have the facts that say what you're doing and applying the letter of law is not making sense with what the law intends. And that's a complicated way of saying that it's an issue that has not been litigated. This one case in Texas is going to be huge in deciding that. It's right now it's still in discovery, it's still going through trial, it hasn't happened with a decision or opinion yet. I will tell you initially in that case, they were originally found, the judge originally dismissed the case on a summary judgment motion, but they appealed and it was overturned. So they are definitely discussing that issue because it was the same situation. They provided more care, they disagreed with the insurance company's determination of care. They also alleged that the insurance company, by forcing a provider to take a certain level of care when they disagreed, it was basically managing medical administration of care and interfering with the physician's determination of medical necessity. Because you as the physician are supposed to have autonomy in treating your patient. An insurance company cannot tell you that the patient needs this or the patient needs X. That's why you're the physician, you're independent, you can't be interfered or have that issue done. But those are issues that are being raised in that one case. And it's something that I think in this particular industry needs to be addressed and litigated more. We're dying to litigate that. We're litigating it in a few areas right now, but nothing head on. We also believe there's parity questions there. We believe the entire, I find it very hard to say that you can go in front of a judge or even a jury in this matter and say, hey, my son was in IOP and they didn't bill me and they kept him at residential and thank God he did because he's alive today. Or, hey, the opposite, I had to discharge him because the insurance company told me to, and now he's dead. I don't think any reasonable person would ever, have an issue with saying that what the insurance companies is doing is wrong. But it's an issue that still needs to be litigated against. Yes?
Yes, hi, Melissa from Metro. We found that if we clinically administrate the GP programs, we utilize their own criteria, and we're able to utilize the lower levels of care and bill for them, and still provide the services that we need to. So that's something that providers should look at. Because litigating is very difficult, as you know.
Yes.
And the federal laws have helped with parity, but Cigna and some of these carriers aren't both.
And I actually completely do agree, and that's one of the points I wanted to bring up again today, that while I'm discussing the law, and there's no great law that I can just say this helps you with all the time. Like I said, it's very complicated. So sometimes practically it makes the most sense to say, how can I do what I need to do and take the time and do it before it becomes an issue and still provide the care and services that I need to my members. So knowing like this issue with downcoding is huge. So you can say, okay, can I take what the insurance companies are saying as my issue and come up with a protocol that I can implement and have systems that I can implement that I can safely step down a patient if need be, or safely be able to bill the patient for the additional services. That's just a practical application of that. Now, just to highlight, again, like I said earlier, the Federal False Claims Act is kind of one of the acts that they rely on, that you're presenting any claim to be false or fictitious. Now, this is a federal statute that relates directly to federal payers. And I want people to be aware of that and understand that, because this is a statute that applies if you present any claim upon the United States government, which is Medicare and Medicaid, to be paid that's false or fictitious. The other statutes that apply to are the healthcare fraud statutes, and this is a scheme to defraud. And a lot of times if you've got an overpayment notice, these are the statutes that they're relying on. They're relying on these federal general statutes that apply. And also I want to highlight some key legal terms here, that for the healthcare fraud statutes to apply, you do not actually have to have knowledge, which means that you can be doing a great job and your biller is doing a great job and your patients are happy. But if you're doing downcoding per se, and that's you're billing downcoding or upcoding to CMS or the federal government, and you have no idea, you're technically in violation of the law. The other thing I want to talk about are the federal anti-kickback statutes. And I get a lot of questions about anti-kickback and patient brokering all the time. And it's a huge industry issue right now and a topic. The federal anti-kickback law only applies if its service is payable by a federal health care program, and that part is underlined. And it can be considered anything that is given in value to another party. So it can be baseball tickets, airline fares, things like that. So I want you to know that. It's not just like I'm paying somebody something, I'm giving him a check, or I'm paying a doctor something. It's anybody, anything. If I say, hey, I'm gonna just like sponsor you at an event, or let me like send you on vacation with your family, those can be considered violations of the kickback. And it also covers solicitation and remuneration. So the actual act is not part, the actual act is, yes, it will violate the law, but if I go up to you and I say I'm like an undercover task force agent for the Medicare government, and I say, well, hey, why don't you give me this and I'll give you that, solicitation is also considered. So that's the actual effort of making the offer, so I'm soliciting it or receiving it. So the point that I'm highlighting in some of these statutes is that they're broad and they can cover different areas. So it's not that I don't pay anybody. We've had a lot of clients who've come to us and said, I've never paid anyone. Not unbeknownst to them, their marketer, great guy, he's going out there saying, listen, just like, I'll give you like cigarettes, or I'll do something, I'll pay for your staff or something. And unbeknownst to the owner or the employer, their staff, uneducated about these laws, are violating it. And then who comes back to bear the burden when something comes up? It's the employer. So be aware of that. Now I want to switch the focus a little bit And my goal is to try to finish this so we have like a half an hour Q&A too. So, but I want to focus on some of the laws that help you, which are Erisa. And again, going back to Erisa, Erisa is a federal law. It governs mainly large employer group plans, and it actually governs the benefit administration of those laws. And it gives providers and patients certain causes of action that you can say, hey, you're not paying me correctly, or you unjustifiably denied me for medical necessity, and things like that. The majority of health insurance plans, if they're through an employer, are under Erisa. Like I said, if you wanted to, you can go online and you go to, I forgot the website, but you can look it up, and if you're interested in the website, I'm happy to give it to you. I'll email it to you. But you can basically go online and see if it's a federally administered plan, which is great because you can say, I can contact the plan administrator, who is either the payer plan, the insurance company itself, or the employer. So a lot of the large employers will have their own plan administration, and it gives you a benefit. And what I recommend is that when you have, say, a patient with a large employer, like Google, or Morgan Stanley, or American Airlines, and you're having issues with the payer to cover services, it gives you an option to go directly to the employer and say, hey, employer, we received such remuneration. We disagree with the payer, your payer, Blue Cross, Cigna, their determination of payment under the benefit. We believe that the patient needs extra additional compensation, or we believe the benefit was not administered properly. And you can say, hey, let's try to negotiate, or I can sue you under Erisa. Erisa does occur in federal court. You do have to have other elements. You have to have an assignment of benefits. You have to be able to sue on behalf of the patient. You have to be able to make sure you've exhausted all other administrative remedies. So those are things that, of course, if you were litigating, you would have to be aware of. But it also gives you, as the provider, an option. And a lot of people probably don't explore that option. So it's something that I would, again, go to your attorney, develop a protocol, and you might want to explore that to try to work directly with the employers. Employers are a lot nicer than the insurance company, so they want to help their patients a lot of times. They don't necessarily want to have their employees in addiction, not succeeding, not being able to work, not being able to do things. And it actually aggravates their costs a lot of time because they're paying for the benefit. If you've ever heard of the term self-funded, that means the employer is funding the cost of the insurance pool that is used to pay off benefits. So the insurance company is not losing any money. It's the employer who loses the money. So they rather work with somebody, make sure it's reasonable, make sure the cost makes sense, than just have the insurance company administratively deny everything, which they always do.